Welcome to Pediatric Case Review Channel. Today we will explore aortic stenosis in pediatric patients, providing you with a comprehensive overview to enhance your clinical knowledge and diagnostic skills. This lecture is designed specifically for pediatric residents. Number: a 6-month-old boy presents with a harsh systolic murmur. Family history reveals father had cardiac surgery as a child. Which etiology of aortic stenosis is most likely? A. Rheumatic heart disease. B. Bicuspid aortic valve. C. Supravalvular aortic stenosis associated with Williams syndrome. D. Hypertrophic cardiomyopathy. The correct answer is B. Bicuspid aortic valve. This is the most common congenital cardiac anomaly, occurring in 1 to 2% of the population. It commonly shows familial clustering with an autosomal dominant inheritance pattern. Other causes include subvalvular membrane, supravalvular stenosis associated with genetic syndromes, and rheumatic disease, which is rare in infancy. A 3-year-old with known aortic stenosis develops increasing fatigue. Which compensatory mechanism explains early symptom prevention in aortic stenosis? A. Left ventricular dilation. B. Left ventricular hypertrophy. C. Right ventricular hypertrophy. D. Increased heart rate. The correct answer is B. Left ventricular hypertrophy. In aortic stenosis, the left ventricle faces increased afterload, causing myocardial hypertrophy to maintain adequate cardiac output despite valvular obstruction. Over time, this compensatory mechanism fails, leading to myocardial fibrosis, diastolic dysfunction, and eventually systolic dysfunction with symptom development. A 7-year-old presents with exertional chest pain and dizziness. Which symptom is part of the classic triad in severe aortic stenosis? A. Palpitations. B. Syncope. C. Cyanosis. D. Hemoptysis. The correct answer is B. Syncope. The classic triad of symptoms in severe aortic stenosis includes exertional chest pain, syncope, and heart failure. Syncope occurs when increased cardiac demand during exercise cannot be met due to fixed obstruction, leading to inadequate cerebral perfusion. These symptoms strongly correlate with disease severity and indicate need for prompt intervention. A 2-week-old infant presents with poor feeding, tachypnea, and diaphoresis. Which form of aortic stenosis is most likely? A. Mild valvular aortic stenosis. B. Moderate valvular aortic stenosis. C. Critical aortic stenosis. D. Supravalvular aortic stenosis. The correct answer is C. Critical aortic stenosis. This severe form presents in the neonatal period with signs of congestive heart failure, including poor feeding, tachypnea, and diaphoresis. These infants often have duct-dependent systemic circulation requiring prostaglandin infusion to maintain patency of the ductus arteriosus. Critical aortic stenosis may be associated with endocardial fibroelastosis and requires urgent intervention. During examination of a 5-year-old with suspected aortic stenosis, which murmur characteristic would you expect to find? A. Holosystolic murmur at apex radiating to axilla. B. Harsh systolic ejection murmur at right upper sternal border. C. Continuous machinery murmur. D. Mid-diastolic rumble at apex. The correct answer is B. Harsh systolic ejection murmur at right upper sternal border. Aortic stenosis produces a characteristic crescendo systolic ejection murmur best heard at the right upper sternal border with radiation to the carotid arteries. Importantly, murmur intensity may not always correlate with stenosis severity, as flow across the valve diminishes in severe cases. An adolescent with aortic stenosis has a slow-rising, low-volume peripheral pulse. What is this finding called? A. Waterhammer pulse. B. Pulsus alternans. C. Pulsus paradoxus. D. Pulsus parvus et tardus. The correct answer is D. Pulsus parvus et tardus. This describes the classic pulse finding in significant aortic stenosis characterized by slow-rising carotid upstroke, tardus, and diminished volume, parvus. This occurs due to obstruction of left ventricular outflow and resultant reduced stroke volume. This finding becomes more evident as stenosis severity increases and helps differentiate from other murmurs. A 10-year-old with suspected aortic stenosis has an ECG performed, which finding most suggests significant aortic stenosis. A. Right bundle branch block. B. Left ventricular hypertrophy. C. ST segment depression in V1, V3. D. Prolonged PR interval. The correct answer is B. Left ventricular hypertrophy. The ECG in significant aortic stenosis typically shows high QRS voltage in left precordial leads reflecting left ventricular hypertrophy. In more severe cases, a strain pattern with ST segment depression and T-wave inversion in lateral leads may be present. However, a normal ECG does not exclude significant disease, particularly in younger children. During echocardiography of a child with aortic stenosis, which parameter best determines severity? A. Aortic valve area. B. Peak instantaneous gradient across valve. C. End-diastolic left ventricular diameter. D. Ejection fraction. The correct answer is B. Peak instantaneous gradient across valve. Echocardiographic assessment of aortic stenosis severity in children primarily relies on Doppler-derived pressure gradients across the valve. Mild stenosis shows gradients below 40 millimeters of mercury, moderate between 40 and 70, and severe above 70. However, gradients must be interpreted considering ventricular function, as reduced contractility can lead to lower gradients despite severe stenosis. A neonate presents with critical aortic stenosis and cardiogenic shock. What is the most appropriate initial management? A. Surgical aortic valve replacement. B. Balloon aortic valvuloplasty. C. Prostaglandin E1 infusion. D. Ross procedure. The correct answer is C. Prostaglandin E1 infusion. In critical aortic stenosis with cardiogenic shock, the immediate goal is stabilization by maintaining ductal patency with prostaglandin E1 infusion. This ensures adequate systemic perfusion as the ductus arteriosus provides an alternative pathway for blood flow. Once stabilized, definitive treatment with balloon valvuloplasty or surgical valvotomy can be performed. A 4-year-old with moderate aortic stenosis with gradient 55 millimeters of mercury requires intervention. Which approach is most commonly used as first-line treatment? A. Mechanical valve replacement. B. Balloon aortic valvuloplasty. C. Ross procedure. D. Medical therapy with beta blockers. The correct answer is B. Balloon aortic valvuloplasty. This catheter-based procedure is typically the first-line intervention for congenital aortic stenosis in children. It effectively reduces the gradient across the valve and delays the need for surgery. The procedure involves balloon dilation of the stenotic valve under fluoroscopic guidance. While generally effective, reintervention may be required as the child grows due to residual stenosis or developing regurgitation. A 12-year-old requires aortic valve replacement. Which surgical option uses the patient's own pulmonary valve? A. Mechanical valve replacement. B. Homograft valve replacement. C. Ross procedure. D. Cano procedure. The correct answer is C. Ross procedure. This operation involves replacing the diseased aortic valve with the patient's own pulmonary valve, autograft, then placing a pulmonary homograft in the pulmonary position. The major advantages include growth potential with the patient, no need for anticoagulation, and excellent hemodynamic performance. However, it's technically demanding and may require reintervention for autograft dilation or homograft stenosis later in life. A 14-year-old with severe aortic stenosis collapses during a basketball game. Which complication likely occurred? A. Aortic dissection. B. Bacterial endocarditis. C. Sudden cardiac death. D. Pulmonary hypertension. The correct answer is C. Sudden cardiac death. Severe aortic stenosis carries a significant risk of sudden cardiac death, particularly during exertion. This occurs due to inadequate coronary perfusion during increased demand, leading to myocardial ischemia, arrhythmias, and cardiovascular collapse. This risk underlies the strict exercise restrictions recommended for patients with severe aortic stenosis and the urgency for intervention when severe stenosis is identified. A child with mild aortic stenosis with gradient 25 millimeters of mercury is being monitored. How often should echocardiographic follow-up be performed? A. Monthly. B. Every 3 to 6 months. C. Annually. D. Every 3 to 5 years. The correct answer is C. Annually. Children with mild aortic stenosis typically undergo yearly echocardiographic evaluation to monitor for disease progression, ventricular function, and development of aortic regurgitation. More frequent monitoring is recommended if there are concerning symptoms, rapid progression in prior evaluations, or other risk factors. Moderate stenosis requires more frequent evaluation every 6 months, while severe stenosis may need assessment every 3 to 6 months. Which factor is associated with worse long-term outcomes after intervention for congenital aortic stenosis? A. Female gender. B. Bicuspid aortic valve morphology. C. Presence of endocardial fibroelastosis. D. Intervention after age 5. The correct answer is C. Presence of endocardial fibroelastosis. This finding indicates more severe and long-standing disease with myocardial involvement and is associated with persistent ventricular dysfunction despite successful relief of obstruction. Other factors associated with worse outcomes include younger age at intervention, smaller aortic annulus size, and more severe initial stenosis. Most patients require multiple interventions throughout their lifetime. A pregnant 16-year-old has moderate aortic stenosis with gradient 45 millimeters of mercury. Which statement is correct regarding management? A. Pregnancy is contraindicated and termination should be recommended. B. Balloon valvuloplasty is recommended in the first trimester. C. Close monitoring is needed with potential intervention if symptoms develop. D. Elective cesarean delivery is mandatory. The correct answer is C. Close monitoring is needed with potential intervention if symptoms develop. Most women with moderate aortic stenosis can complete pregnancy safely with careful monitoring. This includes frequent cardiology and obstetric evaluations, limiting strenuous activity, and prompt treatment of complications. Balloon valvuloplasty can be performed during pregnancy if severe symptoms or heart failure develop. Vaginal delivery with appropriate anesthesia is possible in most cases. Thank you for joining us on Pediatric Case Review for this comprehensive lecture on aortic stenosis in children. We've covered etiology, clinical presentation, diagnosis, management options, and long-term considerations. Remember that aortic stenosis in children requires a tailored approach based on age, stenosis severity, and associated cardiac abnormalities. All patients require lifelong cardiology follow-up, as this is a progressive condition. Please subscribe to our channel for more pediatric cardiology content and leave your questions in the comments section.